So again, for those that have come in late, my name is Craig Lammert. Again, to reintroduce myself, we're going to speak a little bit here over the next 25, 30 minutes about autoimmune hepatitis overview, looking at diagnosis, the etiology, and potential outcomes. I could spend an entire day on this, unfortunately, but I want to try to wrap it up, the best evidence that we have underscoring this disease in the next few minutes. So our aims are to address the burden of autoimmune hepatitis as far as the epidemiology, who does this affect and how many. We want to explore the diagnostic components supporting AIH in individual patients. We also want to review the anticipated disease outcomes. What do we expect in the long run? We then will finally dissect the disease underpinnings and really examine what do we know about the genetics as well as the environmental risk and/or exposures in this disease. A few basic statements that I suspect everyone in the room is aware of. Autoimmune hepatitis is generally unresolving inflammation in the liver unless treated. Has an unknown cause. We see it in all ages, genders, and ethnicities. This is a worldwide disease. This is primarily driven by a type of inflammatory cell from the immune system called the T cell or lymphocyte, attacking the liver cell or hepatocyte. This causes cell death of the hepatocyte, and the resultant healing phenomenon in the liver can lay down fibrosis. This disease can be hard to diagnose, as many of you may have already realized. It's associated with a large number of symptoms, many that are debilitating, and we typically treat patients lifelong with some pretty tough medications or immunosuppressants. In regards to the burden of this disease, the largest epidemiology study looking at autoimmune hepatitis was done in Denmark. It was from 1994 to 2012. It included over 1,700 cases. Now we're going to extrapolate to the United States, and I think we can because the genetic components underlying the Norwegians are probably pretty similar to us folks here in the United States. What they found was, over that time course, there was approximately 1 to 2 per 100,000 people diagnosed. And again, that's incidence. Incidence is a rate. It's the number of patients per year, or per population per year. If you extrapolate that to the United States, which we are approximately 330 to 340 million people, we're seeing about over 6,000 cases each year. Again, that's purely extrapolation. Interesting from the study, they actually identified that the incidence doubled over the course of the study. It went from approximately 1 to 2. That may not seem like much, but if you extrapolate to large population numbers, it's quite significant. The total cases, that is prevalence. These are epidemiology terms. That tells me how many patients currently have this disease per a number, per a population. So in that study, they saw that 24 people out of 100,000 people actually had autoimmune hepatitis. And if they divided it per gender, if you looked only at females, the prevalence was quite higher at 35 per 100,000. Extrapolate that then to the United States, and we suddenly have over 80,000 people with this disease. Now, not all 80,000 people are here. They may not know they have it, or they may not have the means to come. Nonetheless, it files under the rare disease, under the National Institute of Health, says anything less than 200,000 cases in the United States, we will quantitate as a rare disease. This figure here shows nicely the incidence, and again, just to highlight on the left or the y-axis, we see the incident rate per 100,000 people, and on the bottom is the age. What do you see on this figure? So it's actually, the black line is women, the off-white line is men. You can see that there's actually a double hump. And if you look at the literature, we say that the median onset of autoimmune hepatitis is right in the middle, about 40s and 50s. But you actually see from this study, there are actually two peaks in the early age, as well as a very high peak in the late, so 70s to 80s even, which is quite amazing. And you actually can see the women seem to present more commonly later in age. As we've talked already, that this disease comes in many, many flavors, and we can see a wide variety of symptoms at presentation. On the left there, you can be at home and go in for routine lab testing, or you may present right to the hospital. You can be asymptomatic at home, report to your physician, have a normal examination. It can be discovered just by having abnormal liver tests that you got done for your insurance physical. However, on the other end of the spectrum, debilitating symptoms. A large spleen on exam, a large liver, you can have jaundice. You actually may even have liver failure. The symptoms on the spectrum in between there include everything from fatigue to lethargy, disinterest in eating, anorexia, nausea, chronic abdominal pain. We see a lot of joint pain and itching. So again, the symptoms are quite endless, and I don't know if you look at all those and you may check off every one in your mind for your symptoms. This slide highlights what I use to help diagnose autoimmune hepatitis, and this slide may make your head spin, and I'll walk you through it. This actually represents a guideline from our International Autoimmune Hepatitis Group, the AIHG. This was made in 1993 and revised in 1999. This tool was originally developed to help researchers studying this disease to kind of compare apples to apples across institutions. We'll start at the top though. We see sex, and as you can see, you can actually accumulate points, and that's how we get to the bottom. Does this patient have AIH, or is it just probable that they have AIH, or they don't have AIH at all? Sex, 2+ for female. The liver test that Dr. Holden has described, the alkaline phosphatase and AST and or ALT are important in ratio form. We commonly see what we call more hepatocellular injury in this disease, where the AST and ALT should be much higher than the elevations in alkaline phosphatase. And then we'll get to this next piece, which is a very important piece, is the autoantibodies, or the pieces of the immune system that contribute to the diagnosis of this disease. So let's talk about these pieces. Gamma globulins. These are proteins that are made by the immune system, and basically what we need to know is they help to fight infection, whether they're viral and or bacterial. A subgroup of gamma globulins is something called immunoglobulin G. So we actually notice that 75% of all the antibodies that are in the body that also help fight infection are IgG. So this is a very large component. And it's also probably worthwhile to know that they're made by plasma cells. Dr. Cummings later in the day will talk to you and probably show you your first glimpse of what a plasma cell looks like. Here at the bottom is a picture of immunoglobulin G. It's a polypeptide, 4 polypeptides. It has 2 binding sites where it actually binds pieces of foreign material that then trigger the immune system. So again, IgG is an antibody, and as I showed you, it was a Y-shaped protein. It attaches to foreign bodies to help neutralize or activate the immune system. So then taking the next step further is autoantibodies. These are antibodies to self, or proteins in your body that are probably inappropriate. In autoimmune hepatitis, I think it's important to know that this is only a disease marker. This does not identify the cause of pathogenesis or cause. We talk about ANA. It's important to know 50% of healthy individuals have a positive ANA. Smooth muscle protein, which is what asthma or anti-smooth muscle antibody is directed at. And then also anti-liver kidney microsome 1. It's directed at a drug metabolizing enzyme in the liver cell. And again, these are just pieces of putting together the puzzle of does this patient have autoimmune hepatitis or not. Following through here, there's another autoantibody I did not talk about called AMA, and it may be hard to see, so I apologize. That is important in patients with PBC, and also may be important, as Dr. Gare will tell you, in diagnosing overlap phenomenon with patients with PBC and AIH. Viral markers are critical. Viral hepatitis A, B, C, and maybe even E can mimic some of the findings of autoimmune hepatitis. Drugs, as I'll talk here briefly about. Also, alcohol in the form of over 60 grams per day will get you a -2 points because that's a contributing factor of maybe clouding the picture. Alcohol, a regular drink probably has about 10 to 12 grams of alcohol per serving. That's a normalized serving, mind you. The other pieces are also in parts of the immune system, but we don't commonly check, but we will talk about what's called the HLA. Other immune disorders, which, as you know, there's probably many of them, and many of us in the room have more than one autoimmune disease. Other markers, which we talked about, or Dr. Holden said, anti-SLA. Anti-actin is actually a sub-piece of anti-smooth muscle antibody. And these other atypical factors, which are probably not terribly important in most patients with autoimmune hepatitis. Lastly is the histologic features, which the liver biopsy gives us a lot of information. And then lastly, there's a component of treatment response. Does that patient respond to steroids? If you compile these scores up with a score of greater 15 to get a definite diagnosis of PBC or of AIH, we see the true positive rate, which is sensitivity. It's 95%. True negative rate, if you don't hit that mark, of 97%. So actually it's pretty good. However, in reviewing patients' cases, how often do we have all these factors completed? It's not very often. So in 2008, the International Hepatitis Group actually decided, you know what, we need to make something more clinically usable. They decided to condense it to what they thought were the core components of diagnosis. And again, a lot of the same things, but we look at titers now. Anti-smooth muscle, or ANA, with a titer greater than 1 to 40, that just tells me how strong the reaction, how strong the antibody is. And also higher for greater than 1 to 80 gives you more points. Same thing for some of these other atypical autoantigens, SLA and LKM, and then also elevations in immunoglobulin G, along with histology. So again, this simplified things, and we actually saw some decent scores. With anything over 7, we see a true positive rate of 70%. That means there's probably a significant amount of false positives, so you may need to go the extra mile to make sure that this truly is AIH. However, the reassuring thing is the true negative rate of that specificity is about 100%, so that's actually a pretty good test. Let's dissect the types of autoimmune hepatitis, and online this comes up commonly. I don't know how important it is, but we do know phenotypically, so what is different between type 1 and type 2, it could potentially be important in outcomes. We see a characteristic antibody profile, and again, this is pretty much just classic. Now, trust me, people present out of this all the time, because they're actually, the old nomenclature included type 3 and type 4 autoimmune hepatitis. I don't use that anymore, and probably irrelevant, at least at this current understanding. We see that type 1s are commonly with ANA or SMA or both in 80% of the time. This p-ANCA antibody, which is another autoimmune phenomenon, is seen in about 65% of patients. p-ANCA actually may be positive in patients that are seronegative and may be one of the only telltale signs that someone has autoimmune hepatitis. That also including with SLA or anti-SLA. We see that in about 10 to 30% of patients with type 1, as well as type 2 actually. LKM1 is the kind of prototypical autoantigen or autoantibody we see in type 2. And then there's also this other test called the anti-liver cytosol 1 protein we see in about 50% of type 2 patients. We see the onset is different. 10s to the 20s, and then in the 70s for type 1. Again, this is just more classic. People present out of this commonly. Also with the type 2 being more of a young predominant patient, but also maybe more female as well at 90%. Type 1s being more 75% female. So the guys in the audience who have type 1 autoimmune, or have autoimmune hepatitis are a little bit left out, but it's important. As far as the elevated immunoglobulin G, we also see a difference. Commonly very elevated in type 1, occasionally elevated in type 2. And then the presentation can be different too, as far as presenting with mild disease to cirrhosis in type 1, whereas the type 2 patients have a little bit higher propensity to present with more fulminant liver failure or higher frequency of liver failure. Hopefully you've discerned this from my talk, and this is not harped on enough, I think. Again, this goes back to the hammer and nail. We think everyone who has autoimmune hepatitis is probably very different. AIH, in my mind, is primarily an umbrella. And again, I think there are multiple dissections that we will soon, hopefully, delineate, and that may help us to direct better therapy for those specific patients. I want to show you the overall outcomes of some patients with autoimmune hepatitis. If you look at this study that was done in 2011, it was from a non-transplant center community. We actually had 245 patients that presented. This was actually in England, but this is the kind of outcome of what they saw over the course of 1971 to 2007. Of 245, 11 were transplanted. Unfortunately, 70 died, but really only 30 of those cases came from liver disease. And at the end of 2007, 150 patients were actually alive. This does not dissect whether you had treatment response or not, and Dr. Vupalanchi will engage that question a little bit later on today. But they looked at who were high risk for death or liver transplant. A little bit of a morbid topic, but it's something important as a clinician. What do I look for? They found out patients with cirrhosis at diagnosis had 10 times the risk. Again, this does not make it definitive, but it's someone that would be worth watching even closer. Patients that did not undergo treatment had a four times higher risk of progressing to death or transplant. And in patients that have ALT abnormalities beyond a year of treatment, this starts to speculate then on this idea of biochemical non-response. And again, these are the patients that may do worse. I want to introduce you to a complex figure here. This is called a Kaplan-Meier curve. We can explain it very briefly though. This is the time after diagnosis of autoimmune hepatitis starting at time 0. And this is the percent of patients, unfortunately, that died. And you can see in the dotted line here, this is a cirrhotic patient. The curve steepness is actually quite high. You see after 5 years, 20% of patients with cirrhosis in this study were actually deceased. Patients that had no fibrosis and actually a little bit of fibrosis at presentation actually looked the same as far as overall outcomes in death. But around 10 years or so, it actually deviated. This is actually from the Denmark group that I talked about that measured incidence and prevalence before. And what did they identify as factors for bad outcomes? They thought men actually could be a bad phenotype. They may have about 1.5 times the risk of these outcomes as compared to women. We also see, I use this piece of data in my office all the time. Can I drink? I say I don't know. But if you look at the data, alcohol history in this group, they didn't quantitate how they really documented alcohol consumption, but those patients that did imbibe had about 2.5 times higher risk than those that did not drink. We see patients with cirrhosis that not as high as the last study, but we still see a 2 times higher risk of this outcome. Let's talk a little bit about what causes this. Again, another very big question, and I speak about this all the time on social media, genes and environment. And it's something about that interaction, that complex interaction, that regulates the immune system. And as far as one way to think about it is we have effector cells, which can cause damage, and regulatory cells that put the brakes on inflammation. No matter there is some dysregulation that then leads to autoimmune hepatitis. We also now in the past year we've identified, at least from other wet-based laboratories, that maybe these cells, these T cells, they may be deficient and they may not be functioning correctly. This is somewhat of a complex slide, but I'll just walk you through it because I think it's important as far as the genetic underpinnings for this disease. We've known about MHC from 1991. This is actually a protein that produces, or a gene that produces a protein called the MHC class II complex. Ultimately, this gene has been identified with AIH for a long time, and we also know the risk of AIH, if you have a certain subtype, the DR3 or DR4, increases your risk approximately 7 times. However, this is not a causative gene mutation. We see this commonly in a lot of other autoimmune diseases. And what the problem is we see that the way that a plasma cell, also here shown as APC or antigen presenting cell, probably samples its environment and incorrectly stimulates a downstream lymphocyte, basically causing it to break its tolerance to yourself and therefore allowing to attack yourself and in your liver for that instance as well. Where do we know beyond the HLA, which we've known about for years? Let me give you a little bit of a paradigm. PSC and PBC that Dr. Galray will talk about, these diseases are decades ahead of AIH. There's been multiple genetic studies. We've identified 16 genes for PSC and 27 genes for PBC, which is just amazing. Guess what? 1 gene. So there was one genome-wide study, which is a way that we look for genes important in disease. We found 1 gene that contributed to this. It wasn't a terribly large study, but it was enough to say that this gene probably is important. The gene, just for your knowledge, is SH2B3. It doesn't matter, but it does help to regulate the activation of T cells. So it's interesting. Beyond genetics, what about environment? PSC and PBC have also been well studied in this regard. Ultimately, we see that cigarette smoking, coffee, nail polish, drugs, viruses, and food may be big risk factors. Where are we staying with AIH? Well, we know that drugs, maybe, which we're going to talk about, and also viruses and or other viral proteins and or sometimes bacteria possibly as well. Let's talk about viral infections. CMV, which is cytomegalovirus, HSV, or herpes simplex virus, hepatitis A, B, and C have all been associated with this disease. These are pure associations. We don't understand the causation. The hypothesis is that this protein from this virus, or one of these viruses, is actually probably similar enough to one of our proteins in our body that then ramps up the immune system. It may, however, also have a direct effect on the immune system, telling that immune cell to act badly. The virus injury itself may also just cause enough inflammation that if you are genetically susceptible, your immune system may be off to the races. It's already just kind of kicked it in motion. You can't stop the train. Drugs or xenobiotics, we see that there are a lot of associations. Importantly, these drugs, all the drugs that you consume, most of them are metabolized in the liver. We think that that may set up some of the risk in autoimmune hepatitis or drug-induced autoimmune hepatitis. These compounds, that as they're metabolized, go through subsequent steps. These byproducts of metabolism also may, or I hypothesize, can bind to proteins and cause some difficulty in identifying what is drug and what is self, and therefore stimulating the immune system. Looking at drug-induced autoimmune hepatitis, there was a Mayo Clinic study from 2011. They looked at over 260 cases that they had identified over a couple years. They saw that about 10% of cases were drug-related with some degree of certainty. And guess what? The two biggest players, and some of you may know these drugs all too well, minocycline, which is an antibiotic commonly used sometimes for acne, and also nitrofurantoin, which is also known as macrobid. It's one of the frontline agents for treatment for urinary tract infections. The good thing is they found that the AIH, or drug-induced autoimmune hepatitis cases, were basically the same compared to all the other patients with just what we call de novo autoimmune hepatitis, no trigger that was known. The good thing, too, is that there was no cirrhosis at presentation for these patients. The other good thing is we'll talk heavily about probably during this time is they were actually able to withdraw medication for those with suspected drug-induced autoimmune hepatitis with actually a great degree of success. These are established drugs, as we talked about on the top left. Nitrofurantoin and minocycline are some of the most important ones. Those other two aren't really used anymore. There's reports that we see. This list will be available to you after the conference too, just for your own kind of interest. I want to use this point though, there have been herbal associations with drug-induced autoimmune hepatitis. And I want to use this piece just to say supplements are probably not a great thing. We don't know what's in them. And again, we don't understand the interaction with drugs and the liver in triggering or worsening autoimmune hepatitis as well. Speaking of other environmental factors, as I've searched for things that we can talk about that maybe modify or trigger this disease, there's been some interesting data about the stool microbiome. Has anybody heard about this? The bacteria that live in your gut may play an integral role in health and disease, and particularly with the liver, interestingly enough. You actually have over 2 kilos of bacteria in your gut, many trillion bacteria, more than you have cells in your body. And we think these bacteria interact with the liver through the blood supply, as Dr. Holden showed you, dumping a lot of their mediators and proteins and kind of stimulating the liver in many different ways. Dr. Gorham from Columbia looked at what we call a Con-A mouse model. This is a mouse model that we use to study autoimmune hepatitis in the lab. You give them this protein, which is called concavalin A, and actually triggers hepatitis in a mouse, much like the hepatitis we see in humans. Dr. Gorham's found out that if you take mice, the same mice genetically, put them in 2 different environments with different feedings, and you actually change their microbiota, their gut bacteria, because it's so dependent on environment, he actually can change that model and see that there's one model that has more inflammation than the other. He found out that there was a subspecies of bacteria that may drive inflammation. And I only show this slide primarily is because this is really the cutting edge of understanding the way that the gut actually interacts with the liver. And it may be that there's some bacteria that is also modifying or potentially triggering some of our autoimmune hepatitis as well. Vitamin D is a very interesting thing, but I'll give you a word of warning. We see low vitamin D commonly with patients with advanced liver disease, but we've seen low vitamin D in a multitude of other autoimmune disorders. Can I just ask, who knows if they're vitamin D deficient? Have you been checked? So this would be a common thing that maybe providers may not look at, and it may be worthwhile just to ask about. There's a thought that vitamin D may be important in modulating the immune system. We don't fully understand how, but again, you can't deny the association with low vitamin D and other autoimmune disorders. What we see here is in a study that looked at about 50 patients with low vitamin D and normal vitamin D with control patients. We see that between spring and summer, the autoimmune hepatitis patients, they were just low, less than 30 all year round. The controls actually have quite a good vitamin D level. This was a population from Turkey. So again, we see low vitamin D in patients with autoimmune hepatitis, cirrhosis or not. Interestingly though, they looked at the response to these. How do these people do that had low vitamin D? They found that patients that were extremely low, less than 10 international units, had more inflammation and more fibrosis. We also saw that patients with low vitamin D, they were really refractory to therapy. And then in patients with less response to vitamin D, in patients with low vitamin D, they were just really, really hard to get their vitamin D levels up, which also may speak to their underlying liver disease. So take it with a grain of salt, but I think it's an interesting question and probably deserves more attention. Coffee is a great passion of mine. This is some work that I did when I was at Mayo looking at interaction in the liver. Coffee has been heralded as possibly an antifibrotic agent in the liver. We've seen impact on patients in decreasing fibrosis and alcoholic hepatitis C and even fatty liver disease, and maybe even protective against hepatocellular cancer. We actually have seen patients that have high risk for elevated liver tests. If they drink coffee, it may actually improve their liver tests. There's a lot of downstream effects and probably not worth mentioning. But again, I think at this point, I don't tell patients to start drinking coffee if they're not, but if they're doing it, I congratulate them. If you look at PBC and PSC, we did not have AIH patients for the study when I completed it, but you actually can see that PSC patients, not PBC, but PSC, spend a lot less time of their life drinking coffee. And actually, I didn't put this figure on here, but as far as never drinking coffee, the PSC population was much higher. So there may be a piece here, and this is just one other environmental factor that we need to look at a little bit closer. Other environmental factors, I want to compare this triad as Dr. Gowray will in terms of environment. PBC, we see increased risk with smoking, multiple urinary tract infections predisposed to PBC, and there was one study from Dr. Gershwin in 2005 that did see an increased risk of using more nail polish. I don't know what to make of that, but I want to give you the spectrum. PSC, we see that smoking actually can decrease the risk of PSC. However, not so much in patients that have concurrent PSC and inflammatory bowel disease. We see an increase from urinary tract infections association with PSC. We don't know about the nail polish. This is the last point. We don't know. So there's a lot to be done. We'll talk a lot more about how we can contribute and how we can propel this understanding. So in conclusion, AIH we know is complex. We know it's probably resultant from genes and environment. This incidence seems to be increasing, and I don't think we know exactly why. The overall outcomes are good, but as I showed you, there are groups that we probably should watch a little bit closer just based on their natural history of what we've seen from population-based studies. And then finally, maybe if I can click. Further dissection of environment and genetics is really, I think, is going to shed light on AIH by looking at pathways that are important for triggering this. Actually may help us target pathways that we actually then can develop medications to help impact this disease to do better. Thank you.